Equipment Lesson 14 covers radiographic density and contrast. Two of the most tested image quality concepts on the ARRT. Registry. Density and contrast together define whether an image is diagnostic. Too dark, too light, too much gray, not enough gray. Each problem has a specific cause and a specific fix. We cover the definitions, controlling factors for each, the scale of contrast, scatter and fog, contrast media effects, and digital contrast management. 14 minutes. Radiographic density is the overall degree of blackening on the image. It is the primary indicator of adequate exposure. MAS is the primary controller of radiographic density. The relationship is direct and linear, double MAS, double density. Have MAS, have density. No other exposure factor has this precise, predictable relationship with density. KVP has a secondary density effect. Higher KVP increases density because more penetrating photons reach the detector. But KVP primarily controls beam quality and contrast scale, not density. Use the 15% rule to separate these effects. SID affects density through the inverse square law. Longer SID reduces intensity at the detector, decreasing density. Compensate with the direct square law MAS adjustment. And patient and pathology factors. Thicker patients require more MAS, more tissue to penetrate. Additive pathology. Ascites, pneumonia, plural. Effusion, requires more MAS, destructive pathology. Emphysema, pneumothorax. This chart shows 6 factors and their directional effect on image density relative to baseline. Factors that increase density, increasing MAS, the largest and most direct effect. Increasing KVP, secondary but significant. Decreasing SID, moving the tube closer. Increases intensity at the detector dramatically. Factors that decrease density, adding a grid, lead strips. Absorb some primary beam reducing detector exposure. Increasing OID slightly reduces detector exposure due to divergence. And increased filtration, removing low-energy photons. Reduces total beam quantity. Optical density for film, OD equals log base 10 of incident light divided by transmitted light. OD of 0 is clear film, no blackening. OD of 3 is maximum black. No light transmitted. Diagnostic range, 0.5 to 2.5. Digital equivalent, EI, higher EI means more radiation. Reached the detector. D1 of 0 is optimal. D1 above. +1, overexposed. D1 below -1, underexposed. 2 types of contrast, and the registry distinguishes between them precisely. Subject contrast is the difference in X-ray transmission between adjacent tissues, determined entirely by the anatomy. High subject contrast exists between bone and air, they attenuate the beam very differently. Low subject contrast exists between liver and spleen, similar soft tissue. Density. Subject contrast cannot be changed by exposure. Factors. It is inherent to the anatomy being imaged. Contrast media add artificial subject contrast by introducing high-density iodine or barium into anatomical spaces. Image contrast, or radiographic contrast, is the visible difference in density between adjacent areas on the final image. It equals subject contrast modified by processing. And display factors. Short scale contrast, few shades. Predominantly black and white, high contrast, stark. Differentiation. Long scale contrast, many gray shades. Low contrast, subtle tissue differentiation. KVP is the primary controller of Look at the two grayscale bars on this slide. The left bar represents low KVP, 60 to 70 kVp. Short scale, high contrast. Only a few gray shades are visible, stark black, a few intermediate grays, and white. The transition between black and white is abrupt. This is the short scale, few gray levels, high contrast. The right bar represents high kVp, 110 to 125 kVp. Long scale, lower contrast. 7 or more distinct gray levels visible from black through multiple intermediate grays to white. Gradual transitions. Long scale. Low contrast. Why does KVP control this? At low KVP, the photoelectric effect dominates. Tissues of different atomic number absorb the beam very differently, creating large differences in transmission. High contrast. At high KVP, Compton scattering dominates. Tissues of different density produce similar amounts of scatter, creating tools for scatter management. Scatter radiation from Compton interactions exits the patient in all directions. Any scatter that reaches the detector adds fog, reducing contrast. The primary source of contrast degradation in clinical radiography is scatter. At anatomy thicker than 20 cm or technique above 60 kVp, scatter production exceeds primary beam intensity, a grid is required. Grid use removes scatter. Lead strips align toward the focal spot absorb off-angle scatter before it reaches the detector. Contrast improvement factor of 1.5 to 3.0 depending on grid ratio. At the cost of increased MAS, Bucky factor times the original MAS. Collimation reduces scatter production at the source. Smaller field equals less tissue irradiated equals less Compton scatter produced inside the patient. Less scatter produced means less scatter fog on the image. Collimation improves contrast and reduces dose simultaneously. Use it on contrast media work by creating artificial subject contrast between anatomical structures and their surroundings. Iodinated contrast for CT and angiography. Iodine has atomic number 53, high. Photoelectric absorption, appears white on the image. Maximum contrast against surrounding soft tissue. Barium sulfate for gastrointestinal studies, very high. Density, appears intensely white, outlines the GI lumen. Against air and soft tissue. Negative contrast, air or carbon dioxide injected into a space, appears black against surrounding tissue. Used in double contrast studies, barium coats the mucosa. Air distends the lumen, giving maximum mucosal detail. Pathology effects on contrast. Calcifications, calcium is high atomic number, increased photoelectric absorption. Appears white, high contrast against soft tissue. Emphysema, air replaces tissue, decreased density, very dark areas, increased contrast between air and any remaining tissue. Metal implants, very high density. Maximum whiteness, can cause beam hardening artifacts in CT. The window width chart on this slide shows how narrowing the window width dramatically increases visible contrast in digital imaging. The same raw data displayed at different window settings produces entirely different apparent contrast. This is the fundamental difference between film and digital. Contrast management. Film, contrast was fixed by KVP selection and the film screen system. What you exposed is what you got. Digital, contrast is adjustable after acquisition. The radiographer still selects the best kVp for subject contrast, but the display can then be tuned for each diagnostic task. For digital contrast considerations. Post-processing. Window and level adjusts contrast without changing the underlying data. Wide dynamic range, 10,000 to 1 versus 25 to 1 for film. Digital captures extremes simultaneously. Quantum noise, too few photons creates a grainy image that reduces contrast to noise ratio, always maintain adequate MAS for the target EI. And exposure creep, D1 values. Slowly rising over time, monitor systematically. 3 density and contrast questions exactly as the registry frames them. The answer is B, reduce MAS to 1.5 MAS at 120 kVp. MAS is the primary controller of radiographic density with a direct linear relationship. The image is too dark. Overexposed, meaning too many photons reach the detector. Having MAS halves density, bringing it to the optimal range. Reducing kVp would also reduce density but would change the scale of contrast, not desirable for chest radiography where the high kVp long scale technique is intentionally chosen for lung and mediastinal detail. The answer is B, reduce kVp from 80 to 70 kVp. kVp is the primary controller of contrast scale. The answer is C, increase MAS to 45 to 60. Ascites is an additive pathology. Peritoneal fluid accumulation dramatically increases abdomen thickness and density, requiring significantly more radiation to achieve adequate penetration. The standard technique produces an underexposed image. Increase MAS by 50 to 100% depending on the degree of ascites. Even AEC systems increase MAS automatically. The registry tests whether you understand why. You covered radiographic density definition and all controlling factors, the density effects comparison chart. Subject contrast versus image contrast, kVp and the scale of contrast with the grayscale bar visuals, scatter and fog. With all 4 management tools, contrast media effects and pathology influences, and digital contrast management with window width, density and contrast together define image quality, know both cold